Number 1. Bone marrow biopsy. A bone marrow biopsy is still considered one of the most painful modern medical procedures, even with local anesthesia. The goal is to extract a sample of the soft tissue inside a bone, usually the iliac crest, the thick ridge of bone at the back of the hip. The patient lies on their stomach or side while the doctor cleans the area and injects a local anesthetic. The skin goes numb, but the bone itself cannot be fully numbed. That's where the pain comes from. The procedure uses a large hollow needle with a handle designed for force. The doctor presses it against the bone and begins to push and twist. Patients feel a deep, dull pressure at first, followed by a sharp grinding sensation as the needle drills through the bone's outer layer. Some describe it as a crushing or electric pain that radiates down the leg or into the lower back. Once the needle breaks into the marrow cavity, the doctor creates suction to draw out liquid marrow. This part is often the worst. A sudden pulling pain deep inside the bone, unlike anything felt at the surface. The suction can cause an intense, stabbing ache that lasts several seconds. After the liquid sample, the doctor twists the needle again to remove the solid core of marrow. The scraping motion causes more pressure and deep pain. The whole procedure usually lasts 10 to 20 minutes. Even after it's over, many patients have soreness for days, especially when walking or bending. There is no way to make the procedure completely painless because the instruments interact directly with bone tissue, which reacts differently than skin or muscle. For diagnosis of cancers like leukemia or lymphoma, however, it's still the standard method, a necessary test that remains brutally uncomfortable, even with modern medicine. Number 2. Radical mastectomy. In the early 20th century, the Halsted radical mastectomy was the standard treatment for breast cancer. It wasn't just the removal of the breast. Surgeons also took the underlying chest muscle, lymph nodes, and sometimes parts of the rib cage. Even though ether and chloroform anesthesia existed, the post-operative pain was extreme and lasted for weeks or months. The incision stretched from the armpit to the sternum. After the breast tissue was removed, the pectoral muscle was cut away completely, leaving the chest wall exposed down to the ribs. Surgeons then removed cluster of lymph nodes under the arm by digging through fatty tissue. Without today's cauterizing tools, bleeding was controlled with clamps, stitching, and packaged gauze. When the patients woke up, the pain was immediate and overwhelming. The entire upper torso felt bruised, raw, and immobile. Because the pectoral muscle was gone, lifting the arms became nearly impossible. Many women described feeling like their ribs were being pulled apart whenever they tried to move or breathe deeply. Neuropathic pain was common because the surgery damaged nerves across the chest and shoulder. Some lost arm function permanently. Modern mastectomies are far less invasive, but in the early 1900s, the radical version was one of the most physically punishing recoveries a patient could experience. A disfiguring surgery, followed by months of severe, unrelenting pain. Number 3. Rib removal. Opening the chest to access the lungs, heart, or esophagus requires a thoracotomy, a procedure known for having some of the worst post-operative pain in modern surgery. The operation itself is done under full anesthesia, but the recovery is notoriously brutal because of how the chest wall is opened. The surgeon begins by making a long incision between the ribs, usually along the ribs of the torso. Once the muscles are cut, a mechanical retractor is inserted between two ribs. The device slowly cranks the ribs apart, forcing the chest open to create enough space for the surgeon to work. Even though the patient is unconscious, the ribs, cartilage, and intercostal nerves are stretched far beyond their normal range. If access is still too limited, part of a rib may be removed entirely. This involves cutting through bone and separating it from the surrounding tissue. After the surgery inside the chest is complete, the ribs are brought back together and the incision closed. When patients wake up, breathing alone is painful. Every inhale stretches the damaged intercostal muscles and irritates the nerves between the ribs. Many patients require epidermal anesthesia, morphine pumps, or nerve blocks for days just to tolerate basic movement. The pain lingers long after the incision heals. Some people develop chronic neuropathic pain because the retractor crushed or tore intercostal nerves. This can cause months or years of burning, shooting, or aching sensations across the chest and back. Among all fully anesthetized modern surgeries, thoracotomy is consistently rated as one of the most painful recoveries, not because of what happens inside the chest, but because the damage done simply to open it. Number 4. Debridement of burn wounds. For severe burns, the dead skin has to be removed so new tissue can grow. This process, debridement, is one of the most painful procedures performed on conscious patients today. Even with medication, the exposed nerves and burn wounds make every touch feel intense. The session starts by cleaning the burned area with warm water or saline to soften the dead tissue. Then the surgeon or burn nurse begins scraping away the damaged layers using forceps, scalpels, or abrasive pads. Burned skin doesn't peel off cleanly. It comes away in irregular pieces. Each removal exposes raw, sensitive tissue underneath. Burn victims often describe the sensation as burning, stinging, or electrical shocks spreading across the wound. Because large burns cover wide areas, the procedure can last 30 minutes to an hour and must be repeated daily or several times a week. In deeper burns, the tissue becomes leathery and fused to what remains underneath. Removing it requires strong pressure or surgical tools, which creates sharp bursts of pain. Even when sedatives are used, patients often remain partly aware due to the need to avoid full anesthesia for repeated sessions. After the scraping is done, the wound is flushed and covered with fresh dressings. This part is also painful. The new bandages stick to the surface as it heals, and removing them later reopens parts of the wound. The wound heals slightly, then has to be disturbed again. It's not a one-time pain, it's days or weeks of repeated procedures on tissue that has almost no natural protection left. Number 5. Cesarean section. Before modern anesthesia, a C-section meant the mother was fully conscious while the surgeon cut through skin, fat, abdominal muscle, and finally the uterus. There was no numbing beyond alcohol or cloth to bite down on. The pain started with the first incision and intensified as deeper layers were opened. Even today, emergency cases can require a rapid C-section before anesthetic fully takes effect. When that happens, the patient feels sharp cutting at the skin level and intense pressure or burning deeper inside as the surgeon reaches the uterus. Once the baby is delivered, the surgeon still has to remove the placenta and close multiple layers of tissue. This can cause cramping, pulling, and strong internal pain. Patients often describe feeling hands moving inside the abdomen, pressure stretching, and dragging sensations that are hard to tolerate without proper numbing. Post-operative pain is also significant. The incision site pulls with every movement, and the uterus contracts intensely in the hours after birth. For historical patients, infection and hemorrhage added even more pain. C-sections are safe and routine today, but when anesthesia is absent or fails, the procedure becomes one of the most physically overwhelming surgeries a patient can experience. Number 6. Trepanation. In eras before modern surgery, trepanation was performed with the patient fully awake. The goal was to create an opening in the skull using hand tools, usually a sharp scraper, chisel, or drill. It was done for head injuries, seizures, or to release pressure. Long before the science existed to explain what was actually happening, the procedure began by cutting the scalp and folding it back. With no pain control, this alone caused intense burning and stinging. Next came the skull. Surgeons scraped or drilled in a circular motion, removing the outer bone layer, millimeter by millimeter. Patients felt deep vibrating pain as the tool pressed into the bone. As the drill approached the inner layer, the sensation intensified. Too much pressure risked penetrating the brain membrane, so practitioners worked slowly. Many patients remained conscious throughout, describing a mix of sharp pain and overwhelming pressure that built with every turn of the tool. When the bone plug finally came free, air reached the dura, the membrane surrounding the brain, causing a sudden rush of cold, throbbing pain. The wound was then packed with cloth or herbs and left open to heal. Despite the brutality, a surprising number of patients survived, but the immediate pain and shock made trepanation one of history's most feared procedures. Number 7. Kidney stone removal. Before modern medicine, removing a kidney or bladder stone meant performing ileotomy, a procedure done with the patient fully conscious, tied to a table, and held down by several assistants. This surgeon worked through the perineum, the sensitive area between the genitals and the anus. The operation started with a small incision made directly into that region. Even this first cut produced intense pain. After that, the surgeon used metal dilators or fingers to force the opening wider, pushing through muscle and tissue to reach the bladder. Patients often screamed or fainted at this stage. Once the bladder was accessed, the surgeon inserted a long instrument to locate the stone by touch. Then came the extraction. Using hooks, forceps, or even their fingers, surgeons would grab the stone and pull it through the incision. Larger stones tore the tissue on the way out, causing sharp tearing pain that radiated into the abdomen and back. Bleeding was heavy, infections were common, and many patients never walked normally again. Recovery involved days or weeks of intense pain when urinating, along with constant risk of fever or sepsis. Despite all this, Leotomy was performed regularly because untreated stones could be deadly. Some surgeons became famous for their speed, finishing the entire procedure in under 1 minute to reduce how long the patient suffered. Even with its crude tools and extreme pain, Leotomy remained one of the only options for centuries. Among historical surgeries performed without anesthesia, it stands out for its combination of sensitive location, deep cutting, and slow, violent extraction of the stone. Number 8. Limb amputation. Before ether and chloroform became available in the mid-1800s, amputations were performed with the patient fully conscious. Surgeons relied on speed, not comfort. The faster the limb came off, the better the chance of survival, but nothing reduced the immediate pain. The procedure began with assistants holding the patient down. Most were given alcohol or a piece of leather to bite, but nothing dulled the sensation of the first cut. A long knife sliced through the skin and muscle in a single circular motion. The pain was instant and overwhelming. Surgeons were trained to make this cut in seconds to avoid hesitation. Next came the muscles and tendons. These were cut quickly to expose the bone. Patients often screamed, vomited, or lost consciousness at this stage. Once the bone was exposed, the saw was placed against it. This produced a deep grinding vibration that patients felt throughout the body. The sawing itself took anywhere from 10 to 30 seconds, depending on the limb. Bone dust mixed with blood and splinters sometimes tore into surrounding tissue. After the limb came off, the surgeon tied off blood vessels using hot irons or ligatures. This caused another wave of pain. Closing the stump also hurt intensely. Amputation is consistently described as the most agonizing, cutting through every type of tissue while the patient was fully aware of each step.